Hi, everyone, and welcome to today's FAQ. I'm Audrey Gibson, physician assistant from Arthritis Center of North Georgia in Gainesville, Georgia. And today we're tackling an important question. How do clinical manifestations and histopathologic features vary across myositis subtypes? Idiopathic inflammatory myopathies, or IIMs, are a heterogeneous group of autoimmune diseases characterized primarily by muscle inflammation, but they can also involve the skin, lungs, joints, and heart. For APPs in clinical practice, recognizing the difference between myositis subtypes is critical because diagnosis, prognosis, monitoring, malignancy risk, and treatment approach can vary dramatically depending on the subtype. So today we'll walk through a few of the major inflammatory myopathy subtypes, discuss the hallmark clinical features of each, and correlate those findings with histopathology we commonly see on muscle biopsy. So let's dive in. First, let's briefly define the major subtypes we'll discuss today: dermatomyositis, polymyositis, antisynthetase syndrome, immune-mediated necrotizing myopathy, and inclusion body myositis. Although all these conditions fall under the inflammatory myopathy umbrella, they are increasingly understood as distinct diseases with different immunologic mechanisms. So let's start with dermatomyositis. Dermatomyositis is one of the most recognizable inflammatory myopathies because of its characteristic skin findings. Clinically, patients will often present with symmetric proximal muscle weakness. They'll frequently tell me they had difficulty climbing up the stairs or trouble rising from a chair, sometimes difficult lifting objects overhead. But the skin manifestations are often what distinguish this subtype. Classic findings include heliotropic rash around the eyes, Guttron papules, Schall sign, V sign, and mechanic hands in some patients. Patients may also experience dysphagia, interstitial lung disease, calcinosis, or even fatigue. Importantly, some patients have clinically amyopathic dermatomyositis, meaning that they have classic skin disease with minimal or no objective muscle weakness. So let's connect that to the histopathology. The hallmark biopsy feature in dermatomyositis is perifascicular atrophy. This means that muscle fibers at the edges of the fascicles appear small and damaged. We also commonly see perivascular inflammation, complement-mediated microangiopathy. The inflammatory infiltrate is predominantly composed of CD4 positive T cells, B cells, and plasmacytoid dendritic cells. These vascular injury patterns help explain why dermatomyositis affects skin and muscle simultaneously. I think it's an important concept to remember is that dermatomyositis carries an important malignancy association, especially in older patients and patients with antibodies with TIF1 gamma or NXP2. This means malignancy screening is a critical component for management of these patients. Next, let's discuss polymyositis. Clinically, polymyositis presents with symmetric proximal muscle weakness, elevated CKs, myalgias in some patients. But unlike dermatomyositis, there are no hallmark rashes. Histopathologically, polymyositis demonstrates endomysial inflammation, CD8 positive cytotoxic T cells, and invasion of healthy muscle fibers. This is a key distinction. In polymyositis, biopsy often shows diffuse muscle fiber necrosis and regeneration without the perifascicular pattern we see in dermatomyositis. Next, let's move on to antisynthetase syndrome. Antisynthetase syndrome is characterized by autoantibodies, most commonly anti-Jo1. Clinically, these patients may present with myositis, interstitial lung disease, arthritis, Raynaud's phenomenon, fever, and mechanic's hands. One of the key pearls here is that lung disease may dominate the clinical picture. Some patients have relatively mild muscle involvement, but severe ILD. That's why recognizing subtle signs like mechanic hands or inflammatory arthritis may help us identify these patients earlier. Histopathology in antisynthetase syndrome can overlap with dermatomyositis or polymyositis patterns. However, many biopsies show perifascicular necrosis, perimysial inflammation, and fragmentation of connective tissue. This perimysial pathology is particularly suggestive of antisynthetase syndrome. Clinically, these patients often require multidisciplinary care involving rheumatology, pulmonology, and sometimes even dermatology. Monitoring pulmonary function tests and high-resolution CT scan imaging becomes important as following those CK levels. Next, let's take a look at immune-mediated necrotizing myopathy. This subtype is increasingly recognized and can be quite severe. It's commonly associated with anti-SRP antibodies, anti-HMGCR antibodies, and statin exposure in some patients. Clinically, these patients often present with rapidly progressive proximal weakness, markedly elevated CK levels, and severe disability, and in some cases, dysphagia. The defining histopathologic feature is predominantly muscle fiber necrosis with relatively sparse inflammatory infiltrates. Despite this severe muscle weakness and dramatically elevated muscle enzymes, the biopsy may show surprisingly little inflammation. Instead, we can see necrotic muscle fibers, regenerating fibers, and macrophage prominent infiltrates. This pattern reflects the direct immune-mediated muscle injury rather than classic lymphocytic invasion. Classically, these patients often require aggressive immunosuppressive therapy and may need IVIG or rituximab early in their treatment course. Anti-SRP disease in particular may be refractory and associated with significant morbidity. And lastly, let's discuss inclusion body myositis, or IBM. IBM is unique because it's both inflammatory and degenerative features. Clinically, IBM differs dramatically from other inflammatory myopathies. Instead of that symmetric proximal muscle weakness, patients may develop slowly progressive weakness, finger flexor weakness, quadriceps weakness. They often will say they have frequent falls and they have difficulty gripping objects. But in a lot of cases, that weakness is often asymmetric. Patients may also have dysphagia, and one major clinical pearl is that IBM usually affects older adults, often over the age of 50, and progresses slowly over years. Unfortunately, IBM responds poorly to immunosuppressive therapy. Histopathology is very characteristic. Biopsy findings include endomysial inflammation, rimmed vacuoles, protein aggregates, inclusion bodies, and amyloid deposition in some cases. The coexistence of inflammatory infiltrates and degenerative changes is what makes IBM unique. So APP should think about IBM in those older patients with treatment-resistant myositis, especially when distal weakness or finger flexor involvement is present. So what are the major practical points we should remember? First, myositis is not just one disease, and each subtype has distinct features, including clinical manifestations, autoantibody associations, histopathologic patterns, and prognostic implications. Second, muscle biopsy findings can provide critical diagnostic clues, especially when interpreted alongside serologies and clinical phenotypes. And finally, multidisciplinary management is essential. Many patients benefit from coordinated care involving rheumatology, pulmonology, dermatology, neurology, physical, and speech therapy. Again, thank you for joining me today for this FAQ. I hope this overview helps clarify how clinical manifestations and histopathologic findings differ across inflammatory myopathy subtypes and provide some practical clinical pearls that you can apply in the clinic. Thanks again for listening, and visit our WRAP content room and download the WRAP ACE app for more education.